plus arginine, or growth hormone releasing hormone plus GHRP, which is growth hormone releasing peptide, as validated tests. And glucagon is also a very simple validated test. So it's the same glucagon that you give to your diabetic patients. It's a potent growth hormone secretagogue. Now, a word or two about how these tests work, because it's clinically important. But before I go on, clonidine and L-DOPA are widely used to test growth hormone deficiency in children, but in adults, they are virtually unreliable. Mechanisms of growth hormone stimulation. Well, the RTT works indirectly by stimulating the hypothalamus, which then releases growth hormone secretagogues such as growth hormone releasing hormone or GHRP, or inhibits somatostatin, which results in growth hormone release. Arginine and glucagon also acts indirectly through the hypothalamus and depends on hypothalamic secretagogues to release growth hormone. So if you have pituitary damage or hypothalamic damage, and you give the ITT, then you would not expect growth hormone release, and that's the basis of the test. However, if you use GHRH or GHRP given exogenously, coming in on the side, bypassing the hypothalamus, then you're going to give back to the pituitary what it did not receive as a result of hypothalamic injury. And this can cause a false positive test, which is shown in this slide. So this comes from a British group. So they've used the ITT to evaluate peak growth hormone response in a group of pituitary patients and matched to normal. So in normal people, you get a brisk response to the ITT. In patients with pituitary disease, there are two groups. One with apparent normalish responses, the other with subnormal, which is what you might expect, that a portion of patients with pituitary disease will be growth hormone deficient. Then they gave this group of people combined GHRH and GHRP2 tests. So in a normal people, you get a normal response, and that defines the threshold of normality. In the group of patients with pituitary disease, again, you get two groups, one subnormal and one normal. But there are 6 patients here who were growth hormone deficient by the ITT. But with these secretagogues coming in on the side, you can see that they've got an exuberant growth hormone response. So it is clear that one has to be really careful in how we use these growth hormone tests in order to diagnose growth hormone deficiency. So both societies says that a combined test with GHRH or GHRP stimulates the pituitary, may miss growth hormone deficiency of hypothalamic cause, such as from irradiation or traumatic brain injury, and the ITT should be considered if the response is normal in a patient where the degree of suspicion is high. Of course, GHRH plus GHRP, ITT are dynamic tests, and they take time and effort, and they're costly. All of you know you need a patient to come in the morning, they lie on a bed, put in a cannula, you get a good nurse, take samples every 30 minutes, etc., etc. So the question really is, do all patients require growth hormone stimulation tests? Are there clues for us to bypass, a reasonably invasive and expensive test? And people have looked at the degree of hypopituitarism and the IGF status. I think as endocrinologists, and when you treat pituitary patients, we would have to ask ourselves, in a patient with pituitary disease, with a rock bottom testosterone, do you need to do a GnRH stimulation test? How many would do that? Nobody. So I think the same principle applies here. And the Manchester group done an excellent study, a few years old now. And they looked at the frequency of growth hormone deficiency in a group of pituitary patients with growth hormone deficiency diagnosed is an inability to mount a peak growth hormone response to the ITT of over 2.5 nanograms per mil. And then looked at the frequency of growth hormone deficiency as defined by this cutoff in their patients grouped as those with no hormone deficits, with one hormone deficit such as TRH deficiency, with two hormone deficits, and people with, let's say, TRH or ACTH deficiency, or three additional hormone deficits. And the results are pretty clear. The more axes within a pituitary that are damaged, then the likelihood of coexisting growth hormone deficiency becomes very, very high. So those with at least three pituitary hormone deficits, well, the prevalence of growth hormone deficiency is close to 100%. And Hartman and his group has taken this further and evaluated this in a large number of patients, over 800. And this is his experience, that he's found that patients with three pituitary hormone deficiencies have a positive predictive value of growth hormone deficiency of 96%, with four of 99%. If the IGF-1 level itself is low, so this is below the two standard deviations, the positive predictive value is 96. And if you had 3 plus a low IGF-1, then everyone had growth hormone deficiency. So when you're confronted in a clinical situation with this, then your patient really does not need any follow stimulation test. So in the final segment of my talk, now I'd like to touch on some practical aspects of growth hormone therapy and management. The issue of whether sex steroids influence dosage requirements of growth hormone action. And secondly, a frequently asked question. These patients tend to be a little bit obese. Many have the metabolic syndrome. They have borderline glucose intolerance. And you've given them growth hormone, which is a diabetic-genic hormone. What is the net impact on glycemic control? So firstly, on sex steroids. Universally, everyone's noticed that this gender dimorphism in growth hormone responsiveness. This is one example from the Swedish group. And they've looked at what dose of growth hormone is required by men and women followed over a 5-year period. So these two slides tell the same story, but let's just focus on this. So this is growth hormone dose expressed as microgram per kilogram per day. And you can see after a 5-year period, approaching a steady state baseline of dosage requirements. Men require about 5 micrograms per kilogram per day. Women require somewhere between 7 to 8 micrograms per kilogram per day. But you can say, well, what does that mean? You've got to look at some measure of growth hormone responsiveness, which is what they did. They titrated their growth hormone to the IGF level, expressed as IGF standard deviation score. Now, you know that an SDS score of 0 is normal. Okay? SDS score of greater than 2 is too high, etc. So, if you look at men, they all started off with the same dose. There was a marked effect on IGF elevation. In fact, men at the same dose compared to women who were overtreated. So in men, the dose was gradually reduced to within a normal range, whereas in women, they were really struggling to get up there. So despite men needing lower doses of growth hormone than women, the IGF levels on average were higher than those in women. So women are more resistant to growth hormone. So why is that? Well, we've really been interested in this for a while. Most of the women in most of these studies were estrogen replaced, taking estrogens orally. And you know that the liver is a major source of IGF-1. And what oral estrogens do is subject the liver to a first-pass hepatic effect. That the high doses of estrogen, which follows absorption from the gut, knocks down IGF secretion, you lower IGF-1. It also knocks down hepatic fat oxidation. And in the longer term, you would not have an equal benefit in terms of increasing lean body mass or reducing fat mass. And we've tested this hypothesis. And if you look at IGF-1 levels in a group of hypopituitary women before treatment, then we randomize these women either into oral estrogen therapy or transdermal estrogen therapy. It's a crossover design. So even before growth hormone, the same women, when they were taking oral estrogens, had a lower IGF-1. And when they were studied during the transdermal phase, transdermal estrogens. But you could argue, well, maybe these people receive less growth hormone. That's why their IGF levels are lower. But here's the growth hormone dose. You can see, despite receiving the highest growth hormone, their IGF levels were lowest. And if you look at the prevalence of estrogen use in hypopituitary women, it's really pretty terrible. So these are data from the Lilly Hypox database and the Pfizer KIMS database. So in 600 hypopituitary women surveyed, only 5% received the proper type of estrogens. In the KIMS database, 300 people, only about 10%. So as clinicians, we see these people, that is the mode of therapy, not oral. The question is, does testosterone modulate growth hormone action? You know, in as much as estrogens inhibit, maybe testosterone might have the opposite effect. Indeed, it does. And these are some of our data. Studied in a group of hypopituitary men. At baseline, when we look at rates of fat oxidation, growth hormone promotes it. And when you add testosterone, these hypopit men, the effect is amplified. For fat oxidation, it's true for resting energy expenditure. And even extracellular water responds similarly. Growth hormone expands the extracellular water space because it's an anti-natriuretic hormone. When you add testosterone, the effect is amplified. So what we can say is there's a marked regulatory interaction between sex steroids and growth hormone action. The estrogens, when administered orally, antagonize growth hormone, whereas androgens amplify growth hormone action. Then finally, I want to touch on the issue of growth hormone therapy and glucose tolerance. We are always asked the question, does growth hormone negatively affect insulin sensitivity in growth hormone deficient adults? And I wanted to show a slide from Dr. Hu, whom you well know here, who published a really nice paper in JCM. And his paper shows that initially there is deterioration in insulin sensitivity, but as the amount of fat mass goes down, you get a restoration in insulin sensitivity. But I'm sorry, Dr. Hu, I couldn't find my slide of your paper. So, but this is my reserve slide from a Swedish group. So a group of growth hormone deficient people followed over 7 years, undergoing frequent insulin clamps. Now, insulin clamps is a way of assessing insulin sensitivity. And the glucose infusion rate gives you an index of how sensitive you are to insulin. So during the first 6 months of therapy, there's a reduction in insulin sensitivity. But as fat mass reduces, you can see that there's a restoration. So there's a time-dependent change. But what actually happens to glucose itself? And people have looked at fasting, people have looked at 2-hour glucose. And this is a terrific meta-analysis which you should read. So they've looked at effects of growth hormone replacement on cardiovascular risk factors, quite a number of outcome variables, but just focus on glucose. Number of trials, 13, and they're comparing growth hormone and placebo, and the weighted mean change was plus 2 millimoles per liter, so that's tiny. Then I'm also asked, well, these studies don't really tell us who are the risk group, because about 30% of growth hormone deficient people have a metabolic syndrome. So what is the impact of growth hormone on a metabolic syndrome? And here are some Lilly data. And they have analyzed the data from a global database among US patients, shown in red, and European patients, shown here as triangles. And then the overall mean shown just as black bar here. So if you look at the prevalence of the metabolic syndrome, overall it was about 40% in this cohort. And after 3 years of growth hormone therapy, it really didn't change. This is the p-value. And here are the data for the US patients and for the European patients. And the reason why the metabolic syndrome prevalence is high in the US, I think most of you know why, I would say. But what are the effects of growth hormone therapy? You can see there's a reduction in waist circumference. So that's a good thing. And when you look at the other components of the metabolic syndrome, such as fasting glucose, well, there's a worsening, no doubt. When you look at triglycerides, there is a non-significant increase, HDL cholesterol, non-significant change, and blood pressure, a slight rise. So there's a heterogeneous change in the components of the metabolic syndrome. But who are really at risk? And the follow-up data are shown here. So if you look at changes in the prevalence of the metabolic syndrome, who improves and who gets worse? Well, the answer is there. People who are more obese. So in those with a BMI less than 30, the prevalence of metabolic syndrome falls. In those with a BMI greater than 30, when you give them growth hormone, well, you actually make them a little bit worse. So these are the at-risk group. So growth hormone deficient patients with obesity are at increased risk of developing a metabolic syndrome during growth hormone replacement. So to summarize, I think we can say about glucose homeostasis, the effects of growth hormone replacement in this group of patients are minor, they're non-obese, require close monitoring for development of diabetes in the obese, and causes mixed effects on components of the metabolic syndrome. So these are a couple of summary slides. I hope I've convinced you that growth hormone deficiency in adults causes metabolic and psychological dysfunction, which are restored by growth hormone replacement. Can be diagnosed by validated growth hormone stimulation tests and IGF-1 measurements. The dosage requirements are modulated by sex steroids. Optimization of sex steroid replacement therapy has economic implications for growth hormone therapy. And the impact of growth hormone on glucose metabolism is dependent on the degree of adiposity. And I hope I've convinced you that growth hormone is an important metabolic hormone in adult life. And deficiency brings about a whole host of impaired health parameters, can be diagnosed by provocative testing and should be replaced. And last but not least, I want to go back a little bit of time in history. So this is a photo of Maurice Raven, who is really the father of growth hormone therapy. He was amongst the first to extract growth hormone from human pituitary glands. And he reported in the New England Journal in 1962 what he said. about treatment of adult hypopituitarism. One patient, a 35-year-old, was treated with 3 milligrams 3 times a week. After 2 months, she noted increased vigor, ambition, and sense of well-being. Observations will be needed to indicate whether the favorable effect was more than coincidental. Then there are some prophetic statements here. It is not apparent what amount of growth hormone in hypopituitarism is ideal for adults, or whether an additional amount could prevent the changes for aging. And that's very, very provocative. So I'll finish up now, and thank you for your time.
Thank you, Professor Ken, for your very interesting lecture. This is a plenary lecture, so if I may say, we'll have 1 or 2 questions, if there are any from the audience. Professor Ken Ho has a plane to catch. I think you'll be leaving in a few minutes. So, what do you think, Professor Ken Ho, of use of growth hormone among athletes?
It should be banned because it does enhance performance. Simple question, simple answer. But it's widely abused out there, we know that. And the diagnostic tests have not quite caught up with the abuses.
Okay, with that, we'd like to thank Professor Ken Ho for the very interesting lecture. Thank you very much.